It is a huge honor today to be podcast interviewing a dental implant legend, PK Clark. And my little brother is Paul Kenyon, so his nickname was PK too when he was a little kid. But you're actually I thought I was crazy having 4 kids. You actually had 6, so you're actually 50% more crazy than I am.
Pretty much, I think so.
So what are the ages of your kids? From what range are they? Mine are 20 to 26. 20, 22, 24, 26.
Mine are 22 through 34.
Huh. Okay.
And my oldest son is just finishing an oral surgery dual degree at UCSF. We're very proud of him. One of my other sons is a dentist that has joined me at Whitecap Institute. And then I have another son that runs a business called Social Dental that is doing very well. And I have...
What is that? What does Social Dental do?
Social Dental optimizes search engines for dentists. They connect doctors to their patients via all the social networks out there.
Well, let's help Junior out. Tell him to schedule a podcast for me, and he can make his pitch to 7,000 people.
I'll do that. He would love that.
Oh yeah, and I only do podcasts. That's subjects I would do. I mean, I practice dentistry, several days a week, and SEO is what it's at. I mean, I'm so old. I graduated in '87. You graduated in '89, right?
That's correct.
And gosh, the big thing then was to do or not to do the yellow pages. And now the yellow pages are dead, and then it went to the personal computer, and now it's the smartphone, and now I notice that Google is penalizing your dental website if it's not mobile friendly.
Yeah.
So if you're on a smartphone and you search for a dentist, and the guy across the street has a mobile friendly website and you don't, you're not gonna show up first.
Absolutely.
So every dentist wants new patients because that's what we went to school for. Fix up people. I mean, I have to admit, after 28 years, I kind of get tired of the DO and the MO or a single unit crown. My true love is the emergency room. I love toothaches, and that's why I call myself today's dental. And I love just having someone come in and you don't know what you've got, and you got to diagnose it and put out the fire, and you feel like Batman or Superman when you're done because they came in hurting and they leave all fixed up, and it's just the greatest feeling in the world. But hey, I'm glad I have you on because I've wrote a monthly column every month since 1994. And this month's column was absolutely the most controversial. There's people on there saying they'll never listen to Dental Town again or me or whatever the heck. And the subject was, let me just frame the kind of setup. Basically, in the United States with 150,000 dentists, 96% of crowns are done one at a time. And it's the same with implants. Yet whenever you go to continue education, it's always these full mouth rehabs, these Mercedes-Benz, Porsches, all this stuff like that. And then this poor dentist goes back, and 96 times out of 100, it's one tooth. And it's the same with implants. Every time anybody talks about implants, it's always, all on for this big, $50,000 deal. And all I said was, do you really have to have a surgical guide to place the most single common implant, which is just replacing a first molar? I mean, you got a tooth in front, you got a tooth behind, you got a buccal wall, lingual wall of bone. I mean, do you really have to have a $150,000 CBCT and a surgical guide to do this? Because I can find you dentists who have placed thousands of implants who have never used a surgical guide, and I can show you oral surgeons like Jay Resnick in Los Angeles, who's an oral surgeon who uses a surgical guide 100.0% of the time. And my job is to make you think. My job isn't the world according to Howie. I didn't call it howardtown.com. It's dentaltown.com. But as a dental journalist, I hear both sides of the story, so I like to frame Howard Speaks columns to take your mind out for a 5-mile run. But a lot of dentists, they don't want to be challenged. They don't want to, they don't want anybody to say anything they don't agree with. So my first question to you is that question. Do you, and I understand having access to a CBCT to get your anatomy and all that stuff, but do you need a surgical guide to place a single implant, replacing a first molar every single time?
Howard, I've taught 3,500 doctors in the last 12 years how to do implants. And at the end of the day, when you've got adjacent teeth, when you have a lot of bone and good biotype tissue, and you've got an opposing arch. See, that's the thing that no one ever mentions. You've got an adjacent tooth on either side of your question that you're asking me, but you've also got a lower arch. And when that patient bites their teeth down, you've got absolutely everything necessary to put that implant precisely where it needs to go. And what's good for the tooth is not good for the implant. And so that's an interesting thought.
I've never even heard that.
That's PK. This is a PK-ism. What's good for the tooth in the anterior aesthetic zone is not good for the implant because of the proprioceptive component to the tooth allows it to be buckled to a potato chip, or lingualized to a potato chip of bone. But the implant fixture, which is going to be ankylosed to the bone, cannot be in the same position as the tooth because it doesn't have proprioceptive protection. So specific to your question, Howard, the answer is, without question, in my opinion, and I do 1,500 implants a year, so I do a lot of implants. You've got all the right things right there. You've got adjacent teeth. You've got a look at the biotype. You've got a good look at the bone. You've got adjacent or the opposing arch you can bite down to and see that the implant is placed according to three things. The three things that you have to think about when you're placing an implant is very simple. Three things. L, location. Where does that implant fit? Mesial distal, buccal lingual. And then the second component to the equation is the angulation, and that is absolutely dependent upon the opposing arch. Not necessarily the adjacent teeth, the opposing arch, because you want to mitigate deleterious forces that are controlled or propagated, if you will, by the lower arch. So L is location, A is angulation, and D is depth. Where do you want the coronal component or the top of the implant body to be relative to the CEJ and Y? And these are things, so when you get L and you get A and you get D dialed because of the adjacent teeth that are present in the body, and you use the lower arch to see where the lower component of that occlusion fits, you've got a home run. You've got a great deal, and you're going to have a very happy patient. But you have to know that at the end of the day, the goal is stable tissue and stable bone for a long-term preservation of papillas under an implant. And we say all the time to our patients, dozens of times a day, they're just like teeth. They're just like teeth. Yes, they might be in dialogue to a patient just like teeth, but an implant is far from a tooth because it doesn't have proprioceptive protection, it doesn't have the PDL, it doesn't have physiologic movement, and therefore the clinician's got to be very, very wise in protecting that non-proprioceptive fixture from deleterious vector forces that will go in a direction that are inconsistent with the long axis of the implant for long-term stability. I started doing implants in 1988. So I've been doing them for a long time, and I've seen the good and the bad and the ugly, and I've participated in it all. And I'm very, very happy to say that implants are a wonderful thing for our patients. It's all about the patient. And one of the PK-isms I would tell you is that when teeth go away, bone goes away. Simple as that. When teeth go away, bone goes away. And the sole purpose of the periodontium or the alveolus is to preserve the tooth. And when the tooth goes away, we as clinicians have to be very savvy, very, very clever on how to preserve that periodontium and the alveolus. And so, yeah, I agree. 90% of the teeth that are replaced by implants are done one tooth at a time. Not the sexy, exotic, full mouth cases that everybody likes to do. But at the end of the day, it's about that one patient that's missing the one tooth in the one position that is just debilitating them emotionally. And we have the great privilege of restoring that to look like a tooth, but function like a fixture without a periodontal ligament fiber. So occlusion is very, very vital to the success of implantology. But I may have added to your controversy of a month ago. I didn't know about the controversy, but honestly, If someone tells you you've got to place every implant with a surgical guide, I would say, I'm not sure about that. If they said you can place every implant without one, I'm not sure about that. I think you have to look at the case individually, and at the end of the day, be satisfied you did all the preparation necessary to give a patient a tooth that's going to last a long time, look great, function as it should, and do it in a way that's without pain and suffering.
PK, just in case someone's living under a rock, because there's a lot of kids in dental school or just graduated or other continents listening to this. You made the comment that you've educated 3,500 dentists. Tell our listeners about the White Cat Institute, and are you teaching the 90% how to replace that single main teeth, or is it more exotic training? And tell us what you do, and furthermore, how did you get into this? How did you get into teaching dental implants?
I'm just a dentist, and I love my patients, and I've been fortunate enough to get, and I was just at the right place, Howard, at the right time in dental school, where I did my first dental implants in dental school. I went to my dean and I said, listen, I want to do dental implants. And he said, PK, that's going to be impossible. I said, I hate that word. He said, listen, it would take the perfect patient, the perfect mentor that isn't faculty full-time. It would take that faculty member to bring in the equipment and a dental assistant. He went on and on and on. I made a mental note of everything my dean told me it would require. 2 weeks later, I went to my dean and I said, listen, I have the perfect situation. This impossible situation has become possible because of the punch list you gave me. He wasn't thrilled to hear that, as you might imagine. So he said, I want you to promise me, PK, you will not tell anybody while you're in dental school, because the powers that be, all of the political stuff in dental school is going to make this a big, big issue. I said, consider it done. I did my first dental implants in 1988 in the basement of OHSU in Oregon with Dr. John Wagner, a wonderful human that has passed on. Taught me how to do these implants. So I started doing them year after year after year. So at about 12, 15 years of doing implants, my friends would come to me and say, could you help me? And this was a personal epiphany of thought, or a personal wonderful thing that happened to me. I packaged up all my stuff from my office to help my friends. I took an afternoon off, and when I helped my friends do what I had been doing very comfortably for many years, I was blown away. I was satisfied. I was smiling from ear to ear. I was as happy as they were. And at that moment, I thought, is it possible that I could be a pertinent, relevant teacher? Because I didn't think of myself as special. I went home and I talked to my wife about it. I said, I had the crazy thing happen today. I helped my friend do a dental implant in Portland, Oregon, and all of a sudden, all I can think about is helping others help their patients. So I got on a whiteboard and I put everything I loved about CE on one side, the pro of CE. I put everything I hated about CE on the other side. And as you might imagine, the negative of CE far outweighed the positive. And one of the things that really bothered me is the people that were teaching were corporately puppeted. They're all endorsed by corporate America for making money, money, money. No one was talking about patient-centered care. No one was talking about doctor-patient relationship. No one was talking about the stuff that makes me happy at the end of the day. And so I decided to run a course. One course led to another. Hundreds of courses later, I have 3,500 doctors that I consider all but about 7 my friends. Some of the 7 that showed up were just not like-minded. They didn't care for their patients. They were looking for a magic bullet that they could learn everything in a weekend, and that's just not White Cap Institute. So White Cap Institute, I started because of a love for patients and a desire, if you will, to be an example to doctors, old and young, that we need to remember why we're doing this. We're doing it because of patients, and we exist because of them. We should serve our patients, and when we have that doctor-patient relationship in mind, we must epitomize clinical care. And when a tooth goes away, bone goes away, and to optimally help our patients, we need to replace that missing tooth with an implant fixture, properly done, properly aligned, proper location, angulation, and depth, and be very versed in occlusal forces. And so Whitecap, I only teach about 150 new doctors a year. I mentor them after they learn how to do it by protocol-driven implantology. I hold their hand, I emotionally embrace them, I adopt them, and I'm having a blast. This is so fun, and I have doctors that are unbelievably good clinicians doing really, really good outcomes with their implant solutions, and I'm very proud of them. I'm proud of us as a profession meeting the patient's needs. I had an opportunity last week to have an oral surgeon come down from Idaho to be mentored. And I thought, what a great opportunity to cross-pollinate his wonderful medical hospital-based training with my tire meets the road pragmatic training. And I think we need to do more of that. We need to make our patients number one, and a little less territorial, bullying, and be nice about it. I'll tell you why dental implants should be done by general dentists when they are capable of doing it, and when they're not, refer it as fast as you can to a capable clinician, whoever that might be, is because dental implantology, if you really think about it, Howard, is a prosthetic discipline with a surgical component. And by being a prosthetic discipline with a surgical component, who should be better to quarterback it? If the surgical component of that puzzle isn't able to be done by the general dentist in the standard of care set by our periodontists and our oral surgeon friends, then we better let them do it for us, or get someone that can help us mentor and do it for themselves over and over again for their patients. So Whitecap Institute, it's in Heber City, Utah. It's about 20 minutes from Park City. I have everything we do is live surgery. I like the term tire meets the road. I'm so sick of didactic lectures that just hypothecate things and talk about stuff. I want to see it. I want to see it done in real time. I want to be there in the emotion. I want to help our doctors see that things can go wrong. Things can happen in the middle of your intraoperatively that require you to think. Some people that I know, and back to your controversy, if it's okay, is there's some guys that will build a surgical guide by a company, and I had one in my office about a year ago from California mentoring with me, and he put the surgical guide in, and he said, boy, there's very, very wimpy bone. And I said, you missed the bone. He said, how could that happen? My surgical guide was made by a computer. I said, believe me, it happens. He missed the bone. See, so there's distortions in cone beams, there's distortions in the process, but we need to use very good sense. We need to use technology as much as we possibly can, because it's all about the patient. And at the end of the day, if technology makes it better, then use it. If you can do it without the technology as well as with the technology, then do it. But at this point, I don't think the standard of care on that has been determined. I do have 2 cone beams in my office. I use them pre-operatively every time, and I use them post-operatively every time. And I have to tell you, I learn so much when I look at something 3-dimensionally post-operatively. Those of you who have cone beams out there, don't be stingy with them. Take post-operative shots at your endo. Take post-operative shots of your implants.
Which CVCC? Dentists always want me to ask specifically. My whole deal is with Dentaltown, no one's alone. So I know out of 7,000 viewers, someone's saying, well, which cone beam did you get?
And let me say, they're all good, because when you get one, you're going to be so fortunate to be able to see things a 2-dimensional shot won't show you. And then and those of you who don't have the machine, for crying out loud, learn how to read the discs, and they're so easy right now. So it's not an excuse today. I don't have a cone beam to not be able to decipher the information. Specifically to your question, Howard, I'm a CareStream fan. I've got a 9300 and a 9000.
That's what I got. I got the CareStream.
And I've been very happy with CareStream. But they're a solid machine, and I'm not a big computer wizard, and what I love about it is I can get the information every time without a big deal. And they just work.
Okay, these people listening are probably wondering, tell us more about, like, Is it one weekend or is it one weekend a month for 3 months and how much money is it? What is your program? How long? How much? All that.
Thank you. The initial program I'm calling Implant Boot Camp. It's a Thursday, Friday, Saturday. The doctors very easily can get a Utah dental license. It'll take them 9 days and a couple of $100. And they can get a Utah license, and we will mentor them on Saturday to place their first implant under minute-to-minute, second-to-second tutelage. And that is the biggest thing that I could say that we do. The live surgery allows them to pull the trigger on this fearful event on a patient that I've chosen, on a patient that I will take further care of. And so that Thursday and Friday and half-day Saturday, they're learning hands-on procedures for treatment planning. I have boiled it down to 13 questions one has to ask and answer to treatment plan appropriately for all the different circumstances out there. We teach them protocols of implant placement called LAD, the White Cap Way, location, angulation, and depth. We talk about incision design. We talk about reflection tips and tricks and suturing tips and tricks. And when to do a one stage, when to do a two stage, when you would absolutely do a two stage. We go over contemporary medical histories that deserve more discernment from a general practitioner rather than the formality of just simply signing a medical history. There are times as an implant doctor, you don't take the boat off the dock because their medical risk factors are not conducive for safe flying or safe boating that day. But so it's a 3-day course. It's $3,900 and $3,950 or something. That includes us they place the implant. At that point, are you trained to do that? Some guys are, but let's face it, this is a very long pursuit of acquisition of information and experiences, and there's so many good educators out there. The thing that I do better than anybody is I care about my doctors more than anybody. I am a general dentist. I know and feel and live their life, and I can help them integrate implantology into their office in a very safe and predictable way. And that's so important. Safety is so important. Predictability is always not just a happen chance thing. What it is it's predictability comes from protocols. And we'll teach protocols on how to do pain control protocols prior to their surgical experience and afterwards with their patients to be pain-free. But then I mentor with them one-on-one. I mentor about 75, 80 days a year. You rent me and I come. I worked with a wonderful dentist from St. George, Utah yesterday, and he did his first lateral window sinus lift. Do you think that guy was happy? He was so excited. He placed 2 immediate implants. We did it with guided surgery, Howard. We had a guide. It was surgically or computer-driven. But we reflected a big flap, and he opened the lateral window with a technique that I shared with him. And we put in 3.5 grams of BIOS mixed with a high-octane blood. We do all blood draws and use growth factor acquisition. We're using a PRGF. I've used the LPRF. I've used them all. They all work. They're all wonderful. But mentoring is where the absolute growth takes place. I mentored one young doctor from Vernal, Utah, who rented me over 4 years, about 16 days. And he does 450 implants a year.
Now, are you going to his office or is he going to yours?
He's coming to my office. Okay. I've got the cone beam. I've got the big inventory. I've got the blood acquisition stuff. I do the IV sedation with them and for them. I also have an online store that I offer my doctors wholesale Costco prices for all their sutures and biologics and implants and abutments. And then I also have a 5-axis milling company that mills custom bars, all roundhouse zirconia, all under the White Cap name. So we have a White Cap lab, a White Cap store, a White Cap Institute, and a White Cap dental implant center.
And what is the main website that'll get you to all of those?
I don't know. It's, let's see.
White Cap Institute?
Institute would drive you to anything you want.
So you said you had two care streams. What were the two numbers you gave?
9,000 and 9,300.
9,000 and 9,300. So I know someone's saying, well, I'm not going to buy two like you. If I was going to buy one of those two, which one would you buy?
Well, actually, the 9,000, if I understand CareStream's business plan right, is no longer being sold. It's an 8,100. It's a smaller footprint, but it's essentially what the old 9,000 was. And they're selling that like hotcakes in the country. And so as a general practitioner, I would buy the 8,100. You can get stitching to stitch and do a full cranial facial scan if you want, but it is absolutely resolution beautiful. Its exposure to radiation is beautiful. The 9,300's more guys that are doing sleep disease, want to see airways, guys that want to see TMJ joints, want to see, full bilateral views of sinuses, stuff like that. So the 8,100, the predecessor, or the newest machine replacing the 9,000 is probably the thing that most general dentists would want to buy. I think the best buy in the they're probably around, I don't know, somewhere in the high 70s.
70,000 for that.
80,000.
I want to ask you another question I get all the time. The largest dental meeting in the world is every other year in Cologne, and it's like 110,000 dentists show up, and it's a 5-day dental, unbelievable. But there were 274 different companies selling implants. So when you're an individual dentist and she's driving to work right now in her Honda Accord, and she's saying, is titanium, is there value in buying a $500 implant? And am I not going to get a good one if I only pay, 150 for an implant? How do you help this individual decide out of 274 people all selling titanium, all saying theirs is the best? How do you help form that decision?
That's a great question, and I presented some world-class, first of its type research in the Cologne IDS meeting, the last two meetings. So I'm familiar with that huge meeting. It's a wonderful forum and venue, but at the end of the day, I think you want to implant. They've all lost their patents. All of the best of the bells and whistles are boiling to the top. So at this point, you're looking for a company that's doing massive amounts of R&D to improve. For example, right now, the biggest thing in implantology is the nanotechnology on the thread surfaces of the implant body. A lot of implants are mimicking some really good implants, and the implant that I use is called Hyacin. It's an Astratech knockoff. Astratech was bought recently by Dentsply, but it's a Morse taper, power thread, platform switching kind of implant with some really good surface.
You're saying it's an Astratech knockoff?
Uh-huh.
It's a Korean company, isn't it?
That's correct.
And CareStream, your CBCT, that's a Canadian company. Isn't that in Toronto?
It could be. I think so.
But so you're saying Hyacin is it's not Astratech, it's not Dentsply's Astratech, it's a knockoff, but it's South Korean?
Yeah, and it's affordable. Your Astratech is really good for your specialists that don't have the overhead we generalists have, but I can tell you that Hyacin is a subsidiary of Ostem, and Ostem is the parent company, and they sell the most implants in volume of anybody on the planet Earth today.
Spell Ostium.
AOST.
EUM?
IUM.
IUM?
Uh-huh.
And that's the parent company that owns Hyacin?
Yeah.
And you say units-wise they sell the most implants?
Per volume, Ostium is selling the most per volume. It used to be Straumann, and then it was Nobel. Nobel recently was bought by Danaher. Danaher, yeah.
And who owns Implants Direct?
Yes, and they own Implant Direct and all the Cabo Cur companies, but they're a big merger and acquisition company in the U.S., and they just bought that, and I think they bought it for the Chinese market, to be honest. That's my take.
That Danaher bought Noble Biocare for the Chinese market?
Absolutely.
Explain that.
It's hard to get into China, as you might know, and once you're in, then it's easier to just buy the companies that are already in than it is to try to force your way in, because the companies that are already in are closing the doors and saying to the Chinese, you don't need anybody more. Just keep them all out of your boundaries. And so it's a turf battle. And so acquisitions of big companies are being done for those kind of strategic reasons. But back to your question, there's a lot of good implants out there. To me, the surgical kit's one of the most important, and it's overlooked. You need an implant system. I like my surgical choice is Hyacin, and I'm a privateer here. I sell Hyacin in my private store cheaper than anybody can get it through the other stores, because I'm doing it for my doctor friends, and I want them to get the best value they possibly can. But it's a knockoff of AstraTech. It's a platform switching. It's a Morse taper. It's a power thread. It's got all of the surface ingredients you need, and it's priced equivalent to an implant direct.
I think Gordon is coming to my backyard this October, giving a one-day lecture on Hyacin.
Yeah, he's into the one-piece Hyacins for sure. Gordon is just down the road from me. And
can you believe that guy's 80 years old?
You know, I was at his place some time ago, and I couldn't keep up with him. I admire him so much. He's just got all.
I'm 52, and I can't keep up with him, and he's 80. I mean, I'll tell you what, that guy is amazing. Yeah. So you would recommend Hyacin, basically?
I would recommend an implant system that's going to be around in 10 years, that's doing R&D, that has a very great surgical kit. The Hyacin surgical kit has depth stops for every length. I do 5-10 implants a day some weeks. And I'll tell you, as many implants as I've done, Howard, I still appreciate the depth stop. It's fixed to the burr. It's not movable. And then I can use my energy to focus on all the other things that make that implant outcome so vitally important for my patient. So I do love a depth stop. I think it's super safe. If I have to incrementally go closer to an anatomical structure with huge risk value, I go ahead and use that depth stop to creep close without, inadvertently getting where I don't want to be. It's so important that we do more implants for less. I think the implants are too much from a doctor's standpoint. We're charging too much. We got to lessen the fee. We got to do more for more ordinary people, school teachers.
And you sell more. Every time you lower the price, you sell more. I mean, the largest companies in America always go lowest cost. In dental labs, it was Glidewell. They got 5% of the market. In airlines, it was Southwest. In distribution, it was Walmart. It was Costco. I mean, everybody who... the only secret to lower prices is lower cost. And my dad told me that God gave me two eyes, and I'm supposed to keep one eye on the customer and one eye on cost. And he said, God gave you a little brain, and all you're supposed to do is drive down cost so that your customers have the freedom to afford to buy what you buy. And what dentists always do is they always go to these institutes that want to make a mountain out of a molehill. And I mean, if you go to a study club, they just show off like, well, I trim my own dies. The next guy's, I quarry my own stone, then trim my own dies. The next one's like, I have my own beehive to grow my own wax. Then I quarry my own stone. Then I trim my own die. And it takes me 40 days and 40 nights to make one crown, and I sell it to a king for $10,000. And that's not America. That's not the America I know. Henry Ford said it's not technology until it's applied to the masses. And so I want to ask you another controversial part of this article. I said that from 87 to now or whatever, the 28 years I've been a dentist, that we keep going out into a field and building this wooden barn. And then after we build it, we tell the patient to brush it and floss it and use a tongue scraper and Listerine. And then 6.5 years later, the termites go get the barn, and then we blame it all on the patient. And now with implants, we have a chance to go in there and make a titanium barn so that when the termites come back, the Streptococcus mutans, they can't eat it. And some people are saying, okay, titanium can't get a cavity, but it's still getting the periodontal disease with periimplantitis. But I have to tell you that for I'm my diplomat in the International Congress of Implantology. I'm my fellowship in the Mission Institute. I don't think P. gingivalis goes to titanium like it does a nasty periodontally infected tooth where the cementum's all gruddy. And I don't think you can just say you take out a periodontally involved tooth and you still got the bugs in the mouth, and it's going to get peri-implantitis. Do you agree or disagree with that statement?
You know, I'm an observational learner. So, you know, if you want the histology and all of that, you're talking to the wrong guy. But what I do know is I've lived with my implant results now for 25 plus years. I've seen the really good, I've seen some bad and ugly, and I've participated in it, and I'm not exonerating myself from any of that responsibility. At the end of the day, thank goodness, the periodontal disease that is rampantly affecting massive amounts of people in the world does not affect the implant from my observational learning at all. And this peri-implantitis, I think the fuse to it is bad dentistry, bad margins of the abutments to the crowns. It's certainly a seepage of excess cement and ill regard for that. It is a blatant disregard for biologic width. And at the end of the day, that is why peri-implantitis, in my opinion, is taking some people's implants to the cleaners and ravaging the bone and exposing threads and having chronic irritational issues. It didn't start because of bacteria. Bacteria is invading those sites that were propagated by improper margins, cements, contours of crowns, and disregard for biologic width. Now, do I believe for a second that we can get biologic width like we would Sharpie fibers around a tooth that's measured like 1.8 or 2.4, depending on what dental school you went to? No. However, we can mimic it through hemidesmosonal attachments to a fresh, clean titanium or hybrid abutment of zirconia and titanium. But at the end of the day, everybody's building out there popsicles on sticks. The stick is the implant. The little hole that is put the tissue former in a one stage is propagating popsicles on a stick. It's ridiculous. We're not doing emergence profiling the way we should. And in my opinion, what you do to overcome that is you go to good educational clinicians that do it all the time, not just somebody sponsored by a company for a bunch of money, and you learn how to do it for people you love. And those are your patients. And so I think we need to mimic biologic width by putting an implant abutment in a bloody hole. And a bloody hole allows that fresh blood on a sterilized abutment to form a hemidesmosonal attachment, never to be undone again, if it's done right and the screw doesn't loosen or break or some other sequela. But at the end of the day, no one's talking about it. BioHorizons doing some really cool things with laser lock kind of technology. We're starting to hedge that way, but we as generalists have to demand a mimicry of the biologic width on our patients' surgical outcomes and prosthetic solutions on implants. And they'll be long lasting. The tissue will be stable. If tissue's stable, the bone will be stable if the occlusion is right. And that's how I feel.
Okay, PK, I want to slow it down a little bit because you and I are 50, and I've done this for 20 years. How many years have you been doing this now? What,
I've been doing it since 89.
26. Sometimes we forget how much we slowly learned along the way and accumulated, but I know there's going to be, out of 7,000 listeners, there's going to be at least 500 that don't really get the biological minimal width. So you were talking elite. Will you just slow down a little bit and explain what the biological minimum width is to people who are just entering their career?
Well, I think we need to, biological width is a fundamental principle. Well, let's go back here. If we want to put it into histologic terms, let me ask you, Howard, where in our body is our epithelium perforated? Now, I'm not trying to be a smart aleck, but...
gum tissue, sinuses.
Gum tissues. If I take my epithelial finger and put it in my epithelial nose and through the epithelial tract and out the end, it's all epithelium. Same in the ear, same in the eye, same everywhere, except where the tooth penetrates the bone. Our Creator made it possible for that. That's why the cementum of a tooth is at the position it's at, because just above the bone, the Sharpie fibers of the connective tissue shoot themselves into the tooth, forming a biologic seal, keeping blood in and germs out. With that said, the biologic width is simply a barrier of space. Some schools say it's 1.8 millimeters, some say it's 2.2. I don't think it really matters. But the fact of the matter is, it is there. If a general dentist penetrates or violates the biological width in any way, you get chronic irritation. And we do that by not doing crown lengthening appropriately. And we put crowns with margins way below encroaching or in the biologic width. So biologic width is a protective mechanism to protect our body from bacteria. So when we put a dental implant fixture in bone, it's going to osseointegrate and it's going to become one with the bone. However, when we put the connection or the abutment into the implant, at that point, we have to be very, very savvy with our thinking. In the olden days, when you and I started doing implants, Howard, the margin was right at the top of the implant, which was at the top of the bone. Well, that left us no option, and we cemented them in there. We knew no better. No one was telling us any differently. But today, any savvy clinical prosthetic implant person is going to put the margin just below the gum so they can readily clean it up if they're not doing screw retained to begin with, allowing for an unencumbered, clean surface to become biologically somehow connected to that tissue, which I'm going to call a mimic of the biologic width, which is only happening if you have fresh blood when you put your final abutment in. Now, I'm going to ask the audience, and here's my question to you. Have you ever taken a tissue former out and seen it bleed? Absolutely, we all have. When you saw that, did you think that it was inflammation, as I did? Yeah, it wasn't. That abutment went into the surgical site with fresh blood, and that titanium abutment at that time, maybe it's just a tissue former or a healing abutment, they're all the same, went in, hemidesmosonal attachments created a seal, and when we inadvertently took it out, we got blood. Then we put our transfer abutment in, took a final impression, then we put it back in, and then we took it out again when we put our prosthesis in, and we're going to be so clever we don't numb the patient up, so then we put the final abutment in, we never have blood again, we put and cement it, and because we didn't numb them, we don't want to hurt them, so therefore we don't clean it the way we should, and we got a big fat mess. So at the end of the day, biologic width is very important, but you got to have fresh blood and a sterile abutment. How many of you doctors wipe down your abutments with alcohol before you put them in a human? Well, guess what? Your lab tech was either smoking crack at lunch or a tuna fish sandwich with mayonnaise on it. Nonetheless, there's oils from their hands. It's touching that abutment. You've got to think outside the box. Get that abutment clean. Get it sterilized. Numb the patient up. Get the reedy pegs opened up and ready to do something that they've been trained to do. There's not a tooth there, but to adapt itself to whatever the doctor finally puts in there, clean and void of cement. That's the biologic width, and it's in a very quick version.
And answer that question, because should you screw or cement? Because if you don't clean the cement, that's a large problem.
Big problem. And
so if you placed 100 singles, what percent would you screw versus cement?
Well, what year? I did a lot of cement retained, and I thought I was doing it really, really well, and I come to find out that I didn't do it as well as I thought because I've had peri-implantitis, not caused by bacteria, but by cement that I left. I reflect a flap, boom, right there. It's the cement's there. I have a dear friend in Portland, Oregon, oral surgeon, and he says he has about 120 referring doctors. His biggest nightmare is cement. So he'll reflect a flap several times a week, just removing cement. So if you're the purist, which we should be, if you love your patient, you want it to be the very best, when you've mastered all of the little things, I would say, and you only could live in one camp or another, which isn't a fair proposition, but let's just say you could only live in one camp for the rest of your life, it'd be a screw-retained prosthesis for sure.
I want to say, first of all, that I have a lot of dentist friends in Utah, and they all think you're a legend. I mean, they all. I was talking to one this morning, and he told me it'd be my best podcast ever done. I said, really? I've done 130. He goes, he'll be your best. I want to keep getting your amazing mind on controversial stuff. This is a huge controversy. You know, you come from a big family. You have 6 kids. I have 4 kids. I grew up with 5 sisters and a brother, a mom that stayed home, and a dad that delivered rainbow bread. So, I mean, we were so poor we didn't even know we were poor, okay? Um, it seems like if you ever have one of the 30 million people that wear a denture, most of them are a grandma. And if you send them to a dentist, a prosthetist, an oral surgeon, they only present a Mercedes Benz, a $50,000, all on four. So some big implant. It's always 50 grand. So then I think about 90% of America, including a lot of dentists listening to this podcast, don't have 50 grand. And so then they just go home and they're nothing. They never. And then if you suggest on Dental Town, well, maybe you could just go like 4 minis on 3M-bot MTEX, 4 implants on the bottom and 6 implants on the upper. Maybe instead of just a $50,000 treatment, you got a $5,000 treatment. And I swear, on Dental Town, we had to separate in implantology root forms from minis because anybody that poses a mini case is just going to get dived on saying, you can't do that, you can't do that, you can't do that. So I want to ask you this. Do you believe in market segmentation? Do you believe there's such thing as a Chevy and a little more money a Pontiac, a little more money a Buick, a little bit more money a Cadillac, or is it just one Mercedes-Benz fits all?
You know, I don't believe in that at all. I believe in educating your patient to understand what their options are. And I can take a poor patient, and I say poor, I mean somebody that they're living on fixed income, and you can rebase their old denture. You can place 2 implants in a proper position in the mandible, and you can give them a locator, an O-ring, or maybe a stud abutment, an O-ring abutment with a Dalbo, or maybe even do a hater bar with distal extended ERAs, depending on the budget. I believe the minimum on the lower is 2. I believe the minimum on the upper is 4. I don't think the diameter of the implant really matters. The hard costs are so close together. If they've got bone for a 2-piece implant, use a 2-piece implant. If they don't have any bone and you have to put a 1.8 or a 2.2 or 2.8 diameter 1-piece, do it. But when teeth go away, bone goes away. When an implant's put back in, it totally changes the dynamics of that bone and it saves that patient. But I also believe that some of these patients need to have a little more surgery, maybe chop the bone because it's knife-edged. But my biggest gratification in life is helping people that can't eat, can't go out socially. I can do that. I can do an upper-lower case for $10,000, $12,000. Still make money. Oh, absolutely. And the guys that don't.
Is that removable or fixed?
Removable. And here's the thing I've also learned. Don't give somebody that doesn't have a budget a fixed solution that is going to cost a boatload of money to service in the future. Do it right. Give them a removable solution. The problem is if I bite down with a denture, and I might be wrong on this, but I'm just talking metaphorically, about 25 pounds per square inch is all a patient can bite down on their teeth with plates. You give them a couple of implants, you're up into the 200 pound per square inch or something like that. It's quantum leaps. Our older patients deserve it. And when we first got out of dental school, Howard, everybody was so excited about Branimart, but it was $50,000 and $25,000 to train. And these poor people just gave up on it. But we have an obligation to help our patients. When bone goes away, it goes away up and in or down and in. And we have an obligation to support the orbicularosaurus. We have an obligation to give them back physics to masticate their food. These poor people aren't just suffering from ill-fitting dentures. Their whole lives are debilitated. Their phonetics are struggling. Their face is caving in. Their vertical dimension is collapsed. And they're embarrassed and they're humiliated. And as you know, life takes things away from you as you get older. And I think it's a great privilege and an honor to help people like that. And so doctors that have the $50,000 case and that's all they do, shame on them. They need to get a little bit of a grip that their talents they've obtained are there to help other people. And you've got to have a diverse treatment portfolio and a diverse treatment acumen of skill sets to meet these people's needs and do it, for heaven's sakes, not for the almighty dollar, but to just help humanity and feel good at the end of the day you did a good job. Will you make money? Heck yeah, you're going to make money. Don't worry about that. You just need to feel good by making money. And a lot of guys in our profession make a lot of money, but I don't know how they feel good because I've seen some of their work. We need to step it up. We need to be the very best. We need to be the kind of dentists our mothers think we are.
I love that. And yeah, and I had a lady the other day that had me tearing up too because she couldn't wear a denture at night, and she couldn't. The thought of taking out in front of her husband it couldn't happen. So she lied to him and told him that he snores, rolls, kicks. He can't sleep in her room. She got a lock on her door, and then he had to sleep on the couch. And then a year later, he left.
Oh, boy.
And she said, I lost my husband because I never addressed my teeth.
Yeah.
And I just thought that was so sad. She lost love of her life. And yeah, if we don't, Henry Ford, when he made his first Model T, it was $668. And 10 million units later, it was down to $228. He squeezed 2/3 down on the price, and that's why he's a legend. So you're just amazing. I wish you would. I know it's counterintuitive, but if you put a course up on Dentaltown, we have a. I'm thinking of a PK's truisms, or I love the title. What's good for the tooth is not good for the implant. I love all this stuff. But we put up 300 and now I think 25 courses, and they just passed 550,000 views.
Wow.
And I think if you put up a online, they're an hour segments. You did 1 hour, 2 hours, 10 hours, whatever. I think it'd do a lot of good and drive a hell of a lot of people to your center. Because I really want your message to get out more. I think everybody should hear it. So I want you to address this question. A lot of people say the problem with the implants is that the person who never took care of their tooth, they're saying they smoke, they had gum disease, they had cavities. I mean, it's kind of a lot of people are saying there's a reason these people are missing a tooth, and it's because they smoke and they're obese and they're alcoholics. And they got cavities, they don't take care of it and everything. A lot of them think, well, they're not even an indication for an implant because for all the reasons they lost a tooth is why they shouldn't get an implant in the crown. What would you say to that young dentist?
I would say to the young dentist that at first glance they might feel that they're right. But as they grow and experience life, they will come to know that people change. Their priorities change. They grow up. And just simply because they did not appreciate what God gave them originally, they beat it up, they neglected it, they abused it, and lost it. Do we put them in a penalty box for the rest of their life? I say no. I say that they come to appreciate something they've lost after it's lost. And I know that's true for me. I know that's true for people I know. And therefore, I have to know, and I've heard it so many times, these patients are rebooted. They want a quality of life. And I think it's our obligation to, for sure, address the issue, for sure, reboot them into proper maintenance and care of their oral cavity and health. I think that we need to give them credit and not put them in a penalty box for the rest of their life simply because they're smokers, simply because they abuse the teeth. Who are we to make that judgment? I think it's our obligation to treat everybody as well as we possibly can. Let the patient decide what they want. Drive opportunities or options their way. And I can tell you that patients that have had rehabilitation, whether it be the Mercedes or the red wagon, they love it and they're appreciative of it, and they usually take pretty good care of it.
I want you to go back to something you earlier said that went over a lot of people's heads. You started your own lab, your own dental lab, and all those things you're talking about. Describe treatment planning and why you started your lab and what lab services you offer, because you said, okay, low budget, 2 implants, O-rings. Then you said hater bar. They've heard the hater bar, Dolder bar.
Yeah.
No one knows the difference between those two. Explain the 80-20 rule. What is 80% of the things your lab is making? And I assume it's all for implant removable, or is it also implant fixed?
Both. The reason I built the lab is we were doing a bunch of, not to always just offer the Mercedes, but we do a Mercedes, and the lab bills were so astronomical. They were inhibiting me from offering it to the public. And so we were doing about 4 or 5 full mouth cases a month, and we're trying to do all sorts of elaborate solutions. And I bought a 5-axis milling machine from Frankfurt, Germany, called a Datron 5, a Dental 5-axis, with an iMetric white light scanner 5 years ago. I had the first in the country of this type. And I just put it in my dental office, and I hired a CAD/CAM tech, and we just grew. Today we offered our business the first of this year, and we have 90 doctors that use us. We do bars, we do custom titanium abutments, custom titanium zirconia abutments. I have to tell the young doctor I'm not a big fan of all zirconia abutments. Beware of them. I think they will break. I like a titanium base into the implant, and then a zirconia on top of that, and then an EMAX on top of that. But I think I built the lab for me. I now have 2 milling machines, 12 employees, just growing to help our doctors we train. So Whitecap Institute, we train you, we help you buy wholesale pricing for all of your parts and pieces, and then we fabricate what others refuse to fabricate for a reasonable fee. I will do bars on 4 implants for $1,000. Other people are charging a lot more.
Now, a surgical guide is pretty much, if you got a tooth in front and behind, bone on both sides, you might be able to eyeball that, have a CVCT to make sure not anything. But when you're trying to parallel 2 implants or 3 or 4, then you've really got to have it, correct?
Well, I would ask, is it imperative that everything's perfectly parallel? The physics would say it might be better if they were offset just a skosh to be more fundamentally a foundation. But no, I think where you need a surgical guide, absolutely imperative you have a surgical guide, is when you have no reference points. And the typical no reference point game is when there's no goalposts, there's no nothing. It's the edentulous ridges, upper and lower. You reflect a flap, you may have known where midline was prior to your reflection, but after the flap's reflected, you kind of lose where that.
And how are you making a surgical guide? Is your lab making them, or are you taking an alginate and making them on a model?
Guides, old school alginates on models. We make them, we send them out and outsource them to companies like Anantomage or 360 or the company in Reno, I forget. They would be disappointed I don't remember their name. But anyway, there's companies out there that can build surgical guides. But at the end of the day, you can't expect to freehand implants as well as you can prefabricating something to allow you to be better at hitting the bone where you want it. It's a prosthetic game, so you've got to place the implants where the prosthesis need them. And when the prosthesis needs an implant, you've got to grow bones, sometimes you've got to augment, sometimes you've got to ridge split, sometimes you've got to do clever things, because it's not necessarily the number of implants, it's the strategic position of the implants that's probably the most important. I'm not a big all-on-4 guy. I like all-on-5 or 6 or more, but it's all good as long as the price is fair to the patient. Some of these
does an implant company own all-on-4, or do they just have a contract to sell the implants to them?
I think Nobel doesn't own it, but they've certainly adopted it and used it to the maximum way they possibly could. I think as you go to international and national symposiums, the all-on-4 concept is being replaced by all-on-5 or 6. The concept of taking a patient to the operating room, doing all of the surgery, and leaving with the prosthesis in their head is a wonderful thing for the human that receives it.
Well, what I love about the all-on-4 is the millions of dollars of advertising they do each year, and I've had more little old ladies come in with just like a piece of paper or something out of the newspaper or a magazine, and dentists don't realize that when other companies advertise, they're your patients too, and if they love and trust and respect you, their advertising is making them come to you and asking questions. I really wish you would do. I wish you would do so many online courses. I wish you would do one on the practice management of how to do the fees. I know you're an expert in that. I wish you would do the lab work, because when on what your lab makes for treatment planning on a fully edentulous,
yes.
I would give anything, because these people are watching these Like I say, we just passed 200,000 members on Dentaltown. We just passed 35,000 have downloaded the app. So they're watching these courses on their iPhones, their iPads, their computers. And I think the old guys like Brandmark and Mish, they built up a reputation because they were doing a dog and pony show in a physical brick building every weekend their whole life till they, almost, Brandmark's gone and Carl Mish, I hope he's doing well. God, the internet, there's 2 million dentists out there, and we're connected now. I mean, you could give a course, and they could be watching it in Kathmandu while you're asleep. So we're out of time. It's been an hour and 1 minute, but I want to tell you. Oh, last question, because everybody's wondering. When we got out of school, Utah didn't have a dental school. Do they have one now, or do they have two?
They have two, Rosemont and University of Utah.
So University of Utah's in Provo?
No, Salt Lake.
University of Utah. Oh, okay. University of Utah's in Salt Lake. BYU's in Provo.
BYU's in Provo.
And where's the other one? Roseman? Where's that?
It's in the Salt Lake Valley somewhere. I've never been there, but they take 80 students a year. University of Utah's taking 20. So essentially, Utah went from nothing to 80 seats in dental school a year in the last, couple of years.
And you think that was a good thing or unnecessary?
It is what it is. I think it's nice for Utah guys to not leave and spend all the money they would spend to go wherever. I think Utah has too many dentists. No one's going to argue that. I think the Intermountain area has too many dentists. But, wherever you get your training, you make it the very best dental school and just go and do your thing in a community where you want to live.
Do you ever go to southern Utah, South Utah? Because that's what Phoenix is.
That's right.
I think every third person I know was born in Utah. They had to call Phoenix / Utah. But hey, I'm out of time. It's an hour and 1. Man, do you think you might make some online courses?
Of course, I'll do it.
Really? I would just, oh my God, you're an idol. You're a legend. I hear nothing but good things about you. Thank you so much for spending an hour with me today, and I hope to see online courses from you in the future.
Okay, thank you.
And I got a new associate, a young one, and I want to send him to your deal. Yeah, so you'll probably be seeing him. I can't go to your course because I don't have enough discipline. I would start skiing in Park City. I don't know if I have the discipline. I'd probably sneak out the back door. I love snow skiing, and that place it's probably the best ski resort there is.
I think Utah and Colorado probably rock the USA.
But Utah's better than Colorado. I've skied them all a lot. And Utah's just got bigger mountains, less crowds, ski to the lift. I mean, sometimes you can go to Breckenridge and things like all you remembered is waiting in the lift line.
True.
But thank you for all that you do, PK. Thank you very much.
All right. Bye-bye.